is on women's imaging and will be presented by Dr. Maria Anello.
Okay. Hi, my name is Maria Anello. I am at Magee Women's Hospital, UPMC in Pittsburgh, Pennsylvania. And I am going to talk about masters of the uterus with an emphasis on MRI. It's just a play of words. I thought it was similar to Masters of the Universe. Not to date me, but I did watch this when I was younger. So to start, this is a brief overview. We will talk briefly about MRI technique, the uterus, normal anatomy, normal variants, adenomyosis, leiomyomas, uterine sarcoma, endometrial cancer, the cervix, normal anatomy, benign cervical lesions, and then cervical cancer. So our MRI technique here at Magee is dependent on what is to be evaluated. We have specific protocols for fibroids, for endometrial cancer, for cervical cancer, for adnexal lesions, deep endometriosis protocol, etc. We protocol each case prior to being performed and let the technologist know what would be best to image the patient. We have a phased array surface coil. We give an intramuscular injection of an anti-peristaltic to suppress bowel motion, usually glucagon, unless the patient is diabetic. We start with our three-plane localizer. We do an axial T di fiesta. We do axial, sagittal, and coronal FR-FSCT2. Then we'll do T1 FSPGR with and without fat sat to look for any lesion containing fat. Then we'll do a T1 FSPGR fat sat, our LALVA sequence. We have GE, pre and post contrast. For fibroids, uterine cancer, endometrial, cervical will enhance dynamically in the sagittal plane at 30, 60, and 90 seconds after contrast injection. And then we'll do an axial LAVA, pre-contrast, and then post-contrast at 2 and 4 minutes after injection of contrast. So we're going to start talking about uterine anatomy. The uterus varies in length between 7 to 9 centimeters. It varies quite a bit according to age. There are 3 segments of the uterus: the fundus, the body, and the cervix. The fallopian tubes enter into the superior lateral aspects of the uterus known as the cornua. If you draw a line between where the 2 cornua, the fundus lies above this level, the outer contour of the fundus should either be flat or convex. And you can see in this example, incidentally, the woman has an IUD present. The body of the uterus narrows, and as the body meets the cervix, this is called the isthmus. It is the lower uterine segment. The round ligament attaches at the isthmic portion of the fallopian tubes, and as you look on cross-sectional imaging, you can actually see the round ligament connect into the labia majora, so here. So there is a peritoneal reflection on the uterus, and it goes down to the uterus and it reflects between the uterus and the rectum, and this space is known as the pouch of Douglas or the rectouterine pouch. Some anatomy here. The bladder is also called the vesicle. So anterior to the bladder is the prevesical space. Posterior to the bladder, between the bladder and the uterus, is the vesicouterine pouch. And in between the bladder and the vagina is the vesicovaginal septum. Just a brief, another example, a drawing of the uterus, the rectum, the vagina, the anterior and the posterior fornices, our bladder here. Okay. So when we do our deep endometrial protocol, we extend the rectum as well as the vagina with gel, which is nice because it outlines the anatomy. So this is an example of a deep endometrial protocol. As you can see on this uterus, there is a deformity here that is her C-section scar. There are 3 layers of zonal anatomy of the uterus. They are best seen on T2 weighted sequences, the endometrium, the junctional zone, and the myometrium. We'll go through each. The endometrium is our most central part. It is low on T1 and high on T2. The zonal anatomy is best demonstrated on our T2 weighted sequences. It varies in thickness. It's widest during our secretary phase, and in premenopausal patients, it can be greater than 16 millimeters and considered normal. In postmenopausal patients, it is considered normal less than 5 millimeters. Women on hormonal replacement, it can vary between 5 to 8 millimeters. If an endometrium is just incidentally identified on ultrasound, MRI, etc., for different reasons, it can vary from 8 to 11 millimeters. There is no true consensus among radiologists of what we consider, normal. We would like to see it less than 8 to 11 millimeters. And when we see this, we recommend management based on the history. If the patient has any risk factors, etc., tamoxifen usage, obesity, anything that may put her at increased risk for endometrial cancer. So this is just the yellow line demonstrating the endometrium. And another example, our T2 bright signal intensity. The next portion of our zonal anatomy is the innermost layer of the myometrium. It has T2 low signal intensity relative to the myometrium, our junctional zone, shown here. The junctional zone, like the endometrium, is thickest at the time of menses. The junctional zone behaves similarly to the endometrium. Normal is less than 12 millimeters. The junctional zone can be poorly identified in this postmenopausal patient. Incidentally, there's a subserosal fibroid on her uterus. The myometrium is much higher on T2 than junctional zone, but much less than the endometrium. And the myometrium can vary dependent on the hormonal cycle, the age, and other exogenous use of birth control, etc. It can vary, but it is brighter than the junctional zone and less bright than the endometrium. Another example of the myometrium. Okay, so now just to briefly talk about some normal variants. And labor, they also occur just normally during menses as a part of expelling the menses out of the uterus. A clue that it is actually a contraction is that it does not occur during the entire study. This is earlier in the MRI sequences. This is later. By the time we have given contrast enhancement, this finding has resolved. The next topic will be adenomyosis. Adenomyosis is a common disorder. Its prevalence is between 8 to 30% of the population, most commonly between age 40 to 50 in premenopausal patients. Usually occurs more often in multiparous patients who have had prior uterine surgery. These signs are increased bleeding and pelvic pain, as well as an enlarged uterus. And this is just one example of what adenomyosis looks like on a hysterosalpingogram. As you can see, the endometrium is actually expanding with these little saccules of contrast into the myometrium. This is a gross example. You can see the blood products, etc., extending into the myometrium. And this is an MRI example of adenomyosis with the multiple ectopic T2 bright endometrial glands. We'll get more into that. The pathology of adenomyosis is there is an abnormality of the interface of the endometrium and the myometrium. There's a migration of the basal endometrium into the myometrium. The T2 bright signal intensity foci are due to ectopic endometrial glands within the myometrium. And the surrounding T2 dark is due to a hypertrophic reaction of these smooth muscles around the ectopic glands. There are two types of adenomyosis, diffuse and focal. Diffuse, the whole entire interface between the endometrium and the myometrium is affected by the adenomyosis. A direct sign of this is you actually see the T2 bright ectopic endometrial glands. This is another kind of the diffuse. This is an indirect sign in which the junctional zone has increased in diameter and is greater than 12 millimeters. This is just another example of the junctional zone to be thickened greater than 12 millimeters here, measured here. Then there is focal adenomyosis, presenting as a adenomyoma. It's an area of localized adenomyotic glands which form a mass. You can see it is at the posterior aspect of the uterus, and it is an elliptical mass. There are imaging characteristics specific to adenomyosis which help us make the diagnosis. One is being gradual enhancement. This is our T1 fat-sat lava pre, and incidentally you see a T1 bright. This is blood products within portion of the ectopic endometrial gland. And as we can see, it gradually enhances less than the surrounding myometrium. Here we go. Another imaging characteristic specific to an adenomyoma, focal adenomyosis, is this elliptical shape. Also, adenomyosis, a clue to make the diagnosis, is there's lack of mass effect of adenomyosis considering the size. This is a very large adenomyoma, and there is little mass effect on the diameter or the thickness of the endometrium. There is also ill-defined margins. As you can see, there are multiple fibroids that have a pseudocapsule around them, and here's a focus of adenomyosis. There's no pseudocapsule. It's ill-defined margins. The differential for adenomyosis is invasive solid endometriosis, which can attach to the uterus, primary or secondary malignant tumors, something called a low-grade endometrial stromal sarcoma. Metastasis, usually a clue that there is uterine metastasis, is destruction of our zonal anatomy. The uterus is diffusely enlarged. Although rare, we can see uterine metastasis from breast cancer, from gastric cancer, either primary or secondary lymphoma. Treatment of adenomyosis includes medications such as Lupron to help suppress hormonal involvement, hysterectomy, or UFE. UFE usually only gives a transient improvement of symptoms. 44% of menorrhagia will return by 2 years' time. This is something called an adenomyotic cyst. It looks like an endometrioma. It can either be within the myometrium or exophytic, attached to the uterus. You can see this is our T1 fat set, and we have T1 bright blood products. And then on our T2 weighted sequences, it's surrounded by this T2 dark, the hypertrophied muscle. It can again be intramural or submucosal. The next thing we're going to talk about is leiomyomas. Uterine fibroids. They are present in about 20 to 30% of women in reproductive age, 70 to 80% at age 50. 30 to 50% of hysterectomies performed are for leiomyomas. The symptoms can be menorrhagia, dysmenorrhea, pressure, urinary frequency, pelvic and back pain, constipation, obstipation, or infertility. Usually they are low or high or mixed signal intensity on T2 weighted sequences. Fibroids are made up of smooth muscle and fibrous connective tissue. They're attached to a muscular wall of the uterus. They usually have a pseudocapsule. Their growth is affected by hormonal status. Eventually, they outgrow the blood supply and have variable kinds of degeneration. Uterine fibroids have 3 standard locations, and rarely they may be cervical. So they are submucosal, projecting either into or adjacent to the endometrial cavity, subserosal, protruding outside of the uterus, or intramural, surrounded by myometrium. Rarely they can be cervical. This is an example of a submucosal leiomyoma. They're beneath the mucosal lining and immediately to or protrude into the uterine cavity. They're about 5% of fibroids. Submucosal fibroids cause the most symptoms of dysmenorrhea, menorrhagia, and infertility because they can erode into the endometrial cavity and cause a lot of bleeding. And they interfere with normal menses. Also, you can imagine how it could cause infertility as there is limited space for the embryo to implant and limited room for it to grow. This is another example of a submucosal leiomyoma. You can see the thin T2 bright endometrial cavity surrounding this submucosal leiomyoma. Some articles describe that you should try to calculate the largest endometrial interface to the largest dimension of the leiomyoma. And what you do is when you're evaluating this, you take a measurement and you measure multiple times. You have to do it in segments, so a measurement, a measurement, a measurement, a measurement, all the way around of the interface of the submucosal leiomyoma to the endometrium, and you add all of those together, and then you you put the interface over the diameter, the greatest diameter here. And if the interface to the diameter is greater than 0.55, there is an increased risk that this can become intracavitary and exposed after a UFE, or if it's greater than 5 centimeters. So when we review MRIs for patients that considering UFE, we make this calculation, put it in the report, and the interventional radiologist will discuss this with the patient as a possible risk factor and ultimately will help her decide in appropriate management. Rarely, these submucosal fibroids can become pedunculated and protrude into the cervix or vagina. So this is just an example. This is at the top of the uterus. This is actually the stalk. And as we come down, you can see that it has become intracavitary, actually dilating the cervix and coming out of the cervix. And this is a better example how it has become intracavitary. It has dilated the cervix, and it's like she is delivering this. So how they had to remove this was transvaginally. They removed a portion of it, then they went up and took the rest of it out by the stalk. This is another example how this submucosal fibroid became intracavitary and expelled, and now it is expanding the cervix. What happens is if there is an increased risk after UFB, and this does occur, it can necrose and become infected and require emergent hysterectomy. So it's important to discuss this in your report where they are located. The next kind of fibroid is our intramural. It is entirely within the wall of the uterus. The myometrium completely surrounds it. It's the most common, and usually it's asymptomatic. If it's large enough, it can cause compression of the fallopian tube, causing infertility, or lead to menstrual abnormalities by interfering in the contractions. This is just another example of an intramural. See, it's completely surrounded by myometrium. Here is a portion of the endometrial cavity, but there is a separation of myometrium around it. Another example, and you can see this is endocervical canal, endometrial canal. There's still a thick enough portion around it, separating it from the endometrial cavity or cavitary. This is what we call a transmural fibroid. The fibroid has a portion that is adjacent to the endometrial cavity, the endocervical canal. It goes through the myometrium and now is subserosal, called transmural. It's important to describe this in your reporting because it helps the surgeons decide what optimal surgery they will perform, especially if they're doing a myomectomy, possibly to improve fertility chances. A subserosal fibroid is beneath the uterine serosa. Usually they are asymptomatic. Here you can see this large subserosal fibroid. There are certain signs we look to define subserosal fibroids, such as the bridging vessel signs. You can see this T2 signal void between the uterus and this large subserosal leiomyoma. Again, it's little not as well defined, but again, you see these bridging vessels connecting the uterus to this subserosal fibroid. Another sign is it distorts the uterine contour. So here there's abnormal contour of the uterus because of these subserosal fibroids. Another characteristic and something to report is if the subserosal leiomyoma is pedunculated. You need to measure the stalk, and it may or may not allow the patient to have a UAE. One measurement they like to take is the greatest distance of the stalk, the greatest distance or the diameter of the leiomyoma. As long as this is at least half the length of this fibroid, the patient would still be okay to undergo a UAE, or another description is if it's greater than 2 centimeters. If not, it may undergo torsions, or it may just completely torse or necrose and be free within the pelvic cavity and pose many problems for the patient. This is called a broad ligament fibroid. You can see it's coming from the broad ligament. It still has the same classic signal characteristics of a fibroid, and you can often find the bridging vessel sign into the broad ligament. And now we'll describe the characteristics of non-degeneration versus degeneration, which helps plan if a patient is a candidate for UFE. Non-degenerated are well circumscribed, homogeneous, low T2, and they enhance on post-contrast. So you can see all of these are well circumscribed, low on T2 to intermediate on T2, and they demonstrate enhancement. They are non-degenerated. A degenerated fibroid is variable T1 and T2, and it has decreased or no contrast enhancement. So you can see these fibroids are still non-degenerated. Here they enhance on our post, but this large one has undergone degeneration and does not enhance. There are many types of degeneration. The first that we're going to discuss is something called hyaline degeneration. It is characteristically low on T2, and it doesn't enhance. This is an example I found online. I couldn't find any path proven within my saved studies. This is an example of a myxoid degeneration. It's extremely high relative to the other leiomyomas on T2, and it has minimal enhancement. This is a calcific degeneration, which we see oftentimes on CT. I couldn't find an example with MRI, but you could imagine there is T2 dark or signal void on our T2 weighted sequences. This is cystic degeneration. There is high T2 signal here, and then the cystic area does not enhance on post-contrast enhancement. There is something called red or hemorrhagic degeneration. It's due to a hemorrhagic infarction of the leiomyoma. The periphery or the diffuse leiomyoma is T1 high and variable T2. The high T1 at the periphery is believed to be due to blood products in thrombosed vessels. This is an example of this. So this is our T2. It kind of demonstrates variable signal intensity. It's this one here. Again, this leiomyoma here, T2 variable to dark. This is our T1 fat sap pre. We have that increased rim of T1 increased signal intensity from the thrombosed vessel and blood products. And then post-contrast, it does not enhance. Notice that the other leiomyomas do enhance. There's also something called fatty degeneration or lipoleiomyoma. You can see there's a fatty tumor here, subserosal, protruding off the uterus. And our fat sat image, it drops off, demonstrating the fat contents of it. This is called a cellular leiomyoma. There is increased T2 signal. That is because there is compact, smooth muscle with little or no collagen. It demonstrates homogeneous enhancement, and usually it's kind of irregular in configuration. So this is a T2. It's T2 bright. We can see our bridging vessels to it from the uterus, T2 bright. Uterus here, again, T2 bright with some cystic degeneration here. And then our contrast enhancement, it demonstrates enhancement. When the surgeons identify these at surgery, they say that they're kind of friable. They fall apart in their hands. It's not like a typical leiomyoma which, you know, it's encapsulated and they can kind of, I guess, you know, peel out, etc. It's a different feel. Okay, what should we report in our MRI reports? We should include the size of the uterus, a rough estimate of the number, the locations with the maximal size, either in 3 dimensions or 1, the largest dimension. If there is a stalk, if it's pedunculated, the size of the submucosal interface, the enhancement characteristics. Is there adenomyosis present? What does the endometrial lining look like? Is there a mass? Is it irregular within the endometrium? Is there a feeding ovarian vessel? If you can see it, it's difficult to visualize, but it can also help with the interventional radiologist before going to surgery. Are there any adnexal masses? So in articles that I've read, if there's so many fibroids, it might be very difficult to describe them all. It says to describe maybe the 3 largest. But if any beyond the 3 largest has an abnormal location that would affect therapy and treatment, you should describe those as well. This is just an example of pre and post UFE. So here we have our T2 weighted sequence, they're T2 intermediate. After UFE, they've become T2 dark. This is our contrast enhancement. This fibroid had already necrosed, but these other ones enhance, and after UFE, these no longer enhance. So this was 100% infarction of the leiomyomas. This is just another example. And this is actually showing the angiogram, how they have, you know, it's shown both of the uterine arteries. They select each uterine artery out, and they embolize with particles. So now I'm going to go a little bit into unusual or atypical fibroids, such as a stump or a typical fibroid. I'll just briefly talk about these. This woman was in her early 50s, and she had, of course, no medical care. When she presented to McGee, she looked like she was 40-week pregnant with twins. So I actually had biopsied her before going on to surgery, so they had a kind of a clue of what this could be. At surgery, it was described as an atypical leiomyoma. This has increased mitotic activity. The cellular atypia and necrosis is greater than a leiomyoma, but less than used to define a leiomyosarcoma. The pathologist will sample a lot of portions of this, and they have a definition of what meets leiomyosarc versus atypical, or a stump, which I will discuss, and it is less than meeting the criteria for leiomyosarcoma. And you can see how this originated off the uterus. This was 37 centimeters. It was so large that the woman could not lie on her back when getting scanned in the MRI. She had to lie on her side. A stump tumor is a smooth muscle tumor of uncertain malignant potential. They usually clinically are benign, but considered tumors of low malignant potential because occasionally they can recur. Some cases recur years after hysterectomy. Patients diagnosed with stumps should receive long-term surveillance. World Health Organization describes them as a heterogeneous group of uterine smooth muscle tumors that cannot be histologically diagnosed as benign or malignant. And this is this woman's uterus. She was 70 and was having rapid increased size of her uterus with pressure symptoms. You can see it is pressing down on her bladder. When this was interpreted, you know, we were very concerned that it could possibly be a leiomyosarcoma mass growing in a postmenopausal patient. At surgery, it was a stump. This is another example of a 53-year-old woman who is having rapidly increased size of a believed fibroid, and she was having perimenopausal increased menorrhagia. And at surgery, this was found to be a stump. This was another patient. We had 2 patients present within the last year with these very, very large tumors. And this was another patient. Again, she was too large to be scanned on her back in the magnet, and they had to lie her on her side. And at surgery, it was found to be a stump. The next thing we will briefly talk about is uterine sarcomas. Uterine sarcomas are mesenchymal in origin. They're 1 to 3% of all uterine malignancies, very rare. A carcinosarcoma makes up about 40% of them. They were formerly known as malignant mixed mullerian tumors, also called triple MTs. Another kind of a uterine sarcoma is our leiomyosarcoma. A rare type is the endometrial stromal sarcoma, and then there's a few undifferentiated sarcomas. So our carcinosarcoma, or our triple MT, formerly known, is a very aggressive cancer. It is metaplastic. It has both carcinomatosis and sarcomatous components. They usually occur in postmenopausal patients, and they present as abnormal vaginal bleeding. Usually they have uterine enlargement. At presentation, they usually present with an extrauterine disease with stage 3 to stage 4 in a third of the patients. A third of these patients have had pelvic radiation in the past. This is an example of a uterine carcinoma. It was our carcinosarcoma. It's difficult to distinguish from endometrial cancer, but usually it is larger and has deeper myometrial invasion. You can see this one has extended the endometrial cavity and invaded the myometrium. This whole thing has expanded and there's this very thin rim of myometrium and abnormal nodular enhancement within it. This, interesting enough, was triple MT. The woman presented with postmenopausal bleeding. You can see there is an endometrial T2 intermediate mass. It's not the typical appearance. It was a very early, and you can see it enhances less the adjacent myometrium, and it demonstrates restricted diffusion, in which we scan at B sub 0 and B sub 700, and the cellularity impedes the Bronwyn water movement, and you can see it is bright here, and on our ABC map it drops out, demonstrating true restricted diffusion. So this is our uterine carcinosarcoma. Again, very rarely invades the uterus but expands the endometrial cavity, or it very rarely takes over the uterus, I should say, in comparison to a leiomyosarcoma, which we'll discuss next. It enhances greater than the adjacent myometrium, and again, rarely presents as a large mass replacing the uterus. This is an example of a leiomyosarcoma. It's 1 to 2% of all uterine malignancies. Usually they occur in women greater than 40%, is abnormal vaginal bleeding, pelvic mass, pelvic pain, tumor growth, or in a postmenopausal patient. They are 1/3 of all uterine sarcomas. They arise from connective tissue and blood vessels and pre-existing leiomyomas very rarely, or they may arise de novo. So you can see this irregular mass kind of taking over the uterus. The MRI features their variable T1 and T2. They may have infiltrative margins, scattered foci of hemorrhage and necrosis. Usually they do not have calcification. They may or may not involve the endometrium ill-defined margins, and they avidly enhance. So you can see on this woman, she had massive uterine enlargement. At the time of presentation of this massive uterine enlargement, she already had pulmonary metastasis. This is another example. She has irregular hemorrhage and necrosis, and you can see on this post-contrast, all of this is component of necrosis. And again, this is a more superior portion of the previously shown leiomyosarcoma, how irregular it is, T2 mixed, and demonstrating restricted diffusion. Our ABC map here. This is an interesting example of a leiomyosarcoma. This woman was in her early 50s, had abnormal bleeding, and they, did a hysterectomy on her and just happened to identify this as a leiomyosarcoma. Incidentally, they can be identified. A clue that it could be a leiomyosarcoma is it has rapid growth, growth in postmenopausal women. That's why you always want to compare to prior ultrasound, prior MRIs, etc. Try to compare as best you can previously measured leiomyomas. Another clue is that it enhances greater than the adjacent myometrium, which isn't this case scenario. This was a surprise to us that it was a leiomyosarcoma. And then some studies have shown that an LH level may be elevated in patients with leiomyosarcoma. Endometrial stromal sarcomas are very, very rare tumors. The cells look like that of endometrial stroma in its proliferative phase. The MRI demonstrates invasive endometrial mass extending into the myometrium. The tumor extension can go along vessels or ligaments. It's irregular and has intramyometrial nodular extension. This is just one example. I only could find one, and it's the CT. This is the decrease enhancement or decrease attenuation mass, and you can see the irregularity of the adjacent myometrium. They're very rare. It would be hard to differentiate this from an endometrial cancer. Next topic we'll be talking about is endometrial cancer. Endometrial cancer is the most common GYN malignancy in industrialized countries, such as the United States. And in 2013, there were 50,000 new cases and about 8,000 deaths from endometrial cancer. It presents early with vaginal bleeding. In postmenopausal patients, bleeding with an endometrium greater than 5 millimeters is worrisome. The prognosis is determined by the histology grade, the depth of myometrial invasion, lymphovascular invasion, the stage, and the nodal status, but the most significant prognostic factor is how far the depth of the myometrial invasion is. Okay. Just going to get a sip of drink. Okay. Why do we image for endometrial cancer? Sometimes there's confusion. Where is this mass coming from? Is it coming from the cervix, endocervical canal, or the endometrium? We look at MRI to make a prediction of the depth of invasion. We look to see if there's cervical involvement. We look to see if there's regional involvement. If we suspect that it's a severe advanced case, we may consider doing a CT or a PET-CT to look for distant disease. Endometrial cancer is divided into two subtypes. Type 1, FIGO type 1, is endometrioid adenocarcinoma. It's the most common, making 90% of all of the endometrial cancers. It's grade 1, well differentiated, or grade 2, intermediate differentiated. Then there's a type 2. Type 2 is made up of papillary serous which is abbreviated UPSC for uterine papillary carcinoma, and clear cell adenocarcinoma. These are way more aggressive tumors. Type 2 also includes our grade 3 poorly differentiated type of the endometrioid adenocarcinoma. These are more aggressive. At the time of presentation, 50% are already locally advanced, or there are distant metastases at the time of diagnosis. Here is the staging, the FIGO staging. It was updated in 2009, and I'm going to show you an example of each of the stages in the next few slides. This is a nice picture by Netter, which shows the endometrial cancer just barely invading our myometrium. This is also less than 50%. This is showing greater than 50% invasion. This is showing through the myometrium and also involvement of the adnexa and ovaries. Okay, so endometrial cancer on MRI is T2 intermediate signal intensity relative to normal endometrium. And although we don't really have any normal endometrium, we do have a little T2 bright cyst. So you can see it is intermediate, or in comparison to the bladder. Endometrial cancer enhances earlier than endometrium. It enhances less than the normal myometrium, shown here. The greatest time to look for the enhancement is 50 to 120 seconds after contrast. This is endometrial cancer demonstrating restricted diffusion. Again, right on our diffusion and low on our subtraction ABC. And diffusion has been described as helpful to evaluate for myometrial invasion. This is an example of stage 1. So this is the endometrial cancer. See, it is T2 intermediate, and there is less than 50% myometrial invasion. Here it's hard to say if there's any at all. Our next example of our stage 1A, our endometrial cancer, is T2 intermediate, and you can see some thinning of the myometrium here, but pathologically this was less than 50%, so our 1A. This is our 1B, and you can see our endometrial cancer here, and there is thinning of the myometrium, almost loss of myometrium, so greater than 50%. Again, another example of 1B here almost looks like it's gone to the serosal surface, but on path this case was not, it was less or greater than 50% myometrial invasion here and here. That's why it's important to look at all of the planes, the coronal, the axial, the sagittal, because although this does look like it is involved, you can see it is not quite involved, and there's a thin rim of myometrium here. Again, in our reporting, it's a prediction. Ultimately, staging is pathologically at surgery. Okay. Stage 2, tumor invades the cervical stroma but does not extend beyond the uterus. And on our post-contrast, we see the endometrial cancer extending into the cervix. Involvement into the cervical stroma is different than the endometrial cavity extending into the endocervical canal. If it's in the endocervical canal, it is not considered stage 2. It's still considered, stage 1B, okay, or 1A, depending upon the myometrial invasion. This is an example of stage 2. The tumor invades the cervical stroma, but it does not go beyond the uterus. So you can see this infiltrative T2 intermediate is gone into the cervix, heterogeneous enhancement. The cervix does not behave normally. Normally on post-contrast, the cervix remains T2 dark. You can see it's infiltrative into the cervix. This is an example of stage 3. There is either endometrial cancer that has extended through the serosa, or it has extended into the adnexa. And you can see here, this endometrial cancer is involved in this left ovary. You have to be really, really careful when you're evaluating an MRI for endometrial cancer. It is way more common for there to be endometrial cancer involving the adnexa than there to be dual primaries. So you need to be careful when describing an endometrial cancer and an ovarian lesion, as it is, again, more common for it to be involvement of the adnexa than dual primaries. Okay. This is a stage 3 endometrial cancer where there is vaginal or perimetrial involvement. Here you can see this endometrial cancer is extending into the vagina. Here you can see the endometrial cancer is into the perimetrium. You've lost the signal intensity, normal signal intensity of the cervix, and it is now invading the adjacent fat in the perimetrium. This is stage 3B. There is vaginal or perimetrial involvement. You can see there is mets within the vagina here and here. So it's considered vaginal involvement. Stage 3C1 is involvement of the pelvic lymph nodes. You can see they are abnormal in morphology. They do not have a normal appearance of the lymph nodes. They have a signal intensities very similar to our endometrial cancer. This is an example of 3C2 in which there are para-aortic lymph nodes involved. This is one patient. This is another patient. This is why we do our T2 Fiesta axial. We go up through the kidneys and through the area of the retroperitoneum to look for lymph nodes. It's not as, you know, a good of an image as like a CT, etc., but it's a good clue for us to see if there is para-aortic involvement. This is just an example. We suspected it on MRI. The patient went on to have a PET, attenuation correction only, in which this lymph node was FTG avid. Stage 4A is extension to the pelvic wall, lower third of the vagina, or hydronephrosis, non-functioning kidney, or invasion of the bladder or bowel mucosa. So this is path-proven involvement of the adjacent colon. Right here you can see this T2 intermediate mass has extended into the colon. You can see it is involving this portion of the colon. And again, this is the portion right here of the sigmoid colon involved. Stage 4B is a severe case of endometrial cancer with distant omental metastasis in this image. So the next thing we're going to talk about is the cervix. We'll start with normal anatomy. The cervix is the lowest portion of the uterus which protrudes into the vagina. It's surrounded by the vaginal fornices, the anterior and posterior fornices. The vagina begins about halfway down the endocervical canal. The cervix is covered by squamous epithelium. The cervix has the zonal anatomy very similar to the uterus. The endocervical canal here is T2 bright and is contiguous with the endometrium. The inner cervical stroma is T2 dark and it's contiguous with the junctional zone. The outer cervical smooth muscle is T2 intermediate. It is contiguous with the myometrium. The internal os here is the opening into the uterine cavity. It's the supravaginal segment of the cervix. The external cervical os extends into the vaginal vault and its opening of the cervix into the vagina. This is just a funny picture from a colleague. Kind of looks like a smiley face with our cervix here And the ovary, the cysts in the ovaries look like an eye, and the vagina kind of looks like a smiley face. The next thing we'll talk about is benign cervical lesions. So Nabothian cysts are our most common benign cervical lesion. They're benign retention cysts which developed secondary to obstruction of the mucin-secreting endocervical glands. They're usually asymptomatic. They're more common in multiparous patients or patients with prior history of cervicitis. Here's another example. Usually they are less than 2 centimeters, they are high on T2 signal intensity, and they do not enhance. This is a cervical leiomyoma. It's kind of difficult to see, but right here, which you can kind of see better on the post-enhancement, that is our endocervical canal with an IUD in it. And this is arising kind of from this expanded left side of the cervix. This is a cervical leiomyoma. It's important to define this on imaging because it comes from a different blood supply than our uterine leiomyomas. The next thing we'll talk about is cervical cancer. In 2013, there were 12,000 new cases of cervical cancer. There were 4,000 deaths. It is the most common gynecological malignancy in developing countries outside of industrialized countries. That's because there's been such a significant decrease in industrialized countries due to pap smears, and now hopefully it will decrease even more since we're having the HPV immunization. So phygostaging, because it's more common in developing countries, the phygostaging is based on clinical exam. So they recommend doing an MRI when clinically available, but the staging is not based on MRI or imaging. 30% of women will die of their disease. The treatment is surgical versus radiation or chemotherapy. Okay, why do we image these patients with cervical cancer? We look for parametrial extension. We look for pelvic sidewall invasion, for hydronephrosis, for bowel and or bladder involvement, for lymphadenopathy, for distant spread to help the surgeons plan their treatment. Okay, so imaging is not necessary for stage 1A disease because by definition this is less than 7 millimeters. It's microscopic. CT or PET-CT can be considered with patients with advanced disease in which we expect there to be distant spread. MRI may be beneficial for early stage disease such as 1B1 or 2A1 to ensure the patient is receiving appropriate therapy. MRI is beneficial to see if the disease is high in the endocervix. It helps again to determine management. Will this patient be able to have a trachelectomy, a radical hysterectomy, or require radiation? What a trachelectomy is, it's a fertility-sparing procedure in which they remove the portion of the cervix with the cancer. The tumors have to be less than 2 centimeters, the cervix has to be greater than 2 centimeters, and the distance from the cervical cancer to the internal os has to be greater than 1 centimeter. Imaging also helps define how large the disease is. Is it defined as a bulky disease? The measurement of cervical cancer is very highly specific on MRI image. If a patient has a bulky disease greater than 4 centimeters, they are treated like a stage 2B with like a patient who has parametrial involvement. They're best treated with chemo and radiation therapy. There's increased morbidity when they try to take patients with bulky therapy to surgery. Okay, so the phygostaging does not include lymph nodes because, again, it is more common in, in remote countries that have lack of imaging, etc. So it's based on clinical examination. And so you can't really diagnose pelvic lymph nodes on a clinical basis. So it's not included in FIGO staging. However, women who have metastatic adenopathy have a much poorer prognosis. What does cervical cancer look like on MR? It is T2 intermediate to high that replaces the low signal intensity of our cervical stroma here. This is the FIGO staging for cervical cancer, and I'm just going to go through and show you an example of each. This is stage 1B1 disease. There's clinically visible lesion greater than stage 1A, but it's less than 4 centimeters. There's no perimetrial involvement. She's optimal for surgical therapy. So 1B2, I really couldn't find an example. Usually if it's greater than 4 centimeters, it's in the vagina or there's perimetrial extension. I couldn't find any in our database. But you could imagine if the tumor is so big and growing into the endocervical canal, it could possibly be without perimetrial or vaginal extension. Okay, this is stage 2A. There is no perimetrial invasion. It is less than 4 centimeters, and it is involving the upper third of the vagina, but not the lower third. And what the upper versus lower third, or upper 2/3 versus lower third, is defined as the lower 1/3 is if it goes below the base of the bladder. So this is an example of a stage 2A2. So it's greater than 4 centimeters. It's kind of at the cusp because you can see the base of the bladder is here, if it possibly goes to the lower third. But stage 2A2 would not go beyond the lower third of the vagina. So again, if there is no perimetrial involvement like this patient, she would optimally be served by surgical. If it's huge, bulky disease, even though there is no perimetrial invasion on this one, it is too large and the patient would be served best by radiation and chemotherapy. This is stage 2B disease. There is obvious perimetrial involvement. And our surgeons here, even if we have a question, a possibility of perimetrial involvement, the patient is best served being treated like 2B disease. Another example of 2B disease here that is involving the perimetrium. We have loss of this normal low T2 signal of the cervix. It is in the perimetrium. This is an example of stage 3A. There is involvement of the lower third of the vagina with no extension to the pelvic wall, again below the base, lower third of the vagina. This is an example of stage 3B, where there's an extension to the pelvic wall or it's causing hydronephrosis. You can see this left ureter is dilated due to the cervical cancer. This is a gross example of stage 4A in which the cervical cancer has eroded and fistulized into the bladder. The woman is incontinent. This is an example of stage 4B disease. You can see this very, very large cervical cancer with lymph nodes, and this poor woman has liver metastasis at presentation. These are just some of my references here, and that is the end. Do you have any questions? Hello?
I don't see any coming through.
Okay. So feel free to contact me. That's my email. If any questions should arise, I'm happy to answer anything that you may have.
Thank you very much, Dr. Anello. And this lecture was recorded, so I will be sending out the link sometime tomorrow.